All right, thanks for your attention. So I'm going to talk to you guys a little bit about a concept piece about where I think the workup and management of cardiac arrest patients could be going. A big caveat, big asterisk there, could be going. So I think I'll take about 20 minutes of your time to think, to discuss where we might be taking our post-arrest patients. So this is a actual patient I had in fellowship. It's a 60-year-old while watching TV. His wife did immediate bystander CPR. She was CPR trained, had essentially no downtime. At the same time, someone else in the room called paramedics. Paramedics arrived. First thing they did was get him on the monitor. He's in asystole. So he gets transported by ambulance. He gets IV access. He gets a little bit of epinephrine. His rhythm changes, and he's actually in PA, followed by return of spontaneous circulation in the ambulance prior to arrival in the ED. Now, pre-hospital, a 12 lead was done. This is what we saw. And this is actually a pretty ominous 12 lead. We see, I'm not sure if I look for it. We see ABR elevation and diffuse depression. Some people like to call this a STEMI equivalent, and maybe it may not be, but it's a pretty ominous, it's a pretty bad looking EKG. Now, just as this patient rolled into the ED, they had spontaneous circulation, they're still hypotensive, presumably from cardiogenic shock. But as they roll in, the patient goes into VFib. The patient gets shocked, comes back out of it, ROSCOB achieved, and this is our postcode times 2, 12 lead. Again, I'm not an EKG expert, but there's definitely not a STEMI on here. There's no obvious STEMI. So at this point, we have a patient, a 67-year-old. We get a little bit more history. The wife's there. She's distressed. She provides, he is healthy. He's never had a medical problem in his life. You know, no known medical disease. He wasn't doing a bunch of drugs. He didn't overdose on anything. There's no confounders. It's just witnessed sudden cardiac death. And so we have a bunch of different elements. And what the crux of this talk is going to be about is whether or not this patient should be going to the cath lab and how we can make that decision. We have different rhythms, right? We have VFib, we have PEA, we have a bad looking EKG, but it's not STEMI. In my mind, it's not a clear cut decision where this patient's supposed to be going. I know at UK, the answer is this patient's not going straight up to the cath lab. But maybe, and the point of this talk is that maybe we can identify patients that would benefit from coronary angiography, i.e. going to the cath lab, getting percutaneous angiography. So can we take our cardiac arrest patients, and is there a better way to decide who should be going straight up to the cath lab? And so, of course, claps for poignancy. The terminology here, when we talk about cardiac arrest, who needs a cath, is there a lesion that needs to intervene, it gets actually a little muddy. So we have ACS, acute coronary syndrome. And this is a syndrome, which is actually kind of funny because it's one of like the most important diagnoses we make, and it's literally a syndrome. It's not like a hard diagnosis, it's a syndrome. It's manifested by EKG changes, a STEMI, then we get things like labs, we get the troponins. Sometimes we ask about the history, was it unstable angina, these things. That's how we decide whether or not ACS is present. The question is, how well does that actually correlate with an acute arterial occlusion? And this is, again, the crux of this discussion, is what I care about is not whether or not EKG changes occurred from a machine that was invented like 400 years ago, or if labs rise with the sensitivity and specificity, I don't even know. My question is, has there been an acute arterial occlusion of a coronary? And how do we decide if that's the benefit? To confound this a little bit more, so we see a difference between ACS and we see a difference of how that actually correlates with what's actually anatomically happened with our patient. To make things a little bit more complicated, we throw in this term of a culprit lesion. That means we've actually identified something on that cath that we're going to say this actually caused that person to die. This caused their VFib arrest, this caused their asystole, etc. We'll see there's a little bit of a disconnect between these different terminologies. So to preface this whole talk, what we need to know is that heart disease is the #1 killer in the US over the age of 45. Meaning, if I have a 57-year-old who has sudden cardiac death and I said, why did that person die? And you said heart attack, you're right by numbers, just on a numbers game. A 67-year-old, a 71-year-old, why did this patient have sudden cardiac arrest? And you said it was heart related, you're probably right. The prevalence of disease is high. We also know this from autopsy reports. We take every single dead person, we cut them open, and we look at why they die. 65% have acute coronary occlusions in their coronaries on autopsy reports. That's a lot of people. That's the majority of people. So what happens? You know, we get the patient back. What's our workup? How do we identify which of these patients had that anatomical acute coronary lesion, and what does it correlate to the outcome on the cath? So we always get an EKG. Every postcode is getting an EKG. Question is, how well does that predict what gets found on the cath? If we have an EKG, it shows us STEMI. What's the likelihood of an acute arterial occlusion of the coronary? Okay, it's pretty good, up to 98%. Most studies show 98%. So if you have a STEMI after arrest, yeah, you probably had acute coronary occlusion. That makes sense. We all have appreciated that for over 25 years. Here's the other thing. If you just take all the people who go to the cath lab after arrest, regardless of what their EKG shows, more than 75% of them do not have STEMIs. You know, it's great when we see a STEMI because we know what to do. The truth of the matter is very few with known acute coronary occlusions actually have EKG changes. My T-wave inversions, ST depressions, maybe ABR elevation, some of these other things that we call STEMI equivalents, maybe none of those. Maybe it's a normal EKG, and these patients, up to 75% of them, have coronary occlusions on cath. Okay, what about troponins and echo, right? That's our next step. We looked at the EKG, no surprise, it's non-specific. What a bedside echo. Now, this is an echo of someone's heart in short axis view. This has a wall motion abnormality. Half of the heart isn't squeezing and the other half is. That's awesome. If I see that and I can correlate it with a history that suggests heart attack, a wall motion abnormality plus cardiac arrest, I'm definitely worried this person has an acute arterial occlusion. This is a TEE on a live person. When I do point of care ultrasound in cardiac arrest patients, this is what it looks like. It looks like trash because the patient's been getting chest compressions. I can't see anything, like 2/3 of the time. What about our troponins? We order troponins to just try and decide, did this patient have an acute arterial occlusion? When it comes down to it, the numbers don't support these tests. We do them, don't get me wrong, we do them. They're just bad. Poor sensitivity, poor specificity. Someone could have an echo that looked bad before they had a heart attack. I don't know if that caused their arrest. Their troponins go up because they arrested. You know, it's going to happen in almost every single one of our patients. So the answer is, these don't ultimately add that much in deciding who needs to go to the cath lab after arrest. What about key historical points? Complaining of chest pain, chest clutching, saying the words, I'm dying of acute coronary occlusion before arrest. You know, I wish, but these don't really add up to anything. They have no predictive value for who is actually having that coronary occlusion. Here's the big one. Here's the big one. Initial rhythm. VFib, initial rhythm of VFib, right? That has to be a heart attack. Does that sound somewhat familiar to you guys? VFib means this is cardiac. In 2015, the AHA guidelines said if your initial rhythm after in cardiac arrest was VFib or pulseless VTAC, it was reasonable to consider immediate catheterization after arrest. And they also had a bunch of hedges in there too. You know, if the patient isn't comatose, if their pH is okay, if their lactate's okay, all this stuff that like basically isn't the case in dead people. So how good is this VFib VTAC anyways? How often does a VFib arrest predict a finding on a cath lab? 2012, 34% of VFib VTAC patients had acute coronary occlusions. 26%, 29.7%, 27%. If they died of an initial rhythm of VFib VTAC, this is the percentage that they found acute coronary occlusion. Now that means something. Don't get me wrong, the numbers are pretty consistent. If you have VFib or pulseless VTAC, there's a good chance, a roughly 26 to 34% chance that you have an acute coronary occlusion. But we know people going to VFib and VTAC for all sorts of reasons. Hypoxia can lead into VFib. You know, some other kind of prolonged QT syndrome, et cetera, et cetera. We know there's a reasonable chance there's a coronary syndrome, but we're not 100% sure by any means. So let's take the flip side of this. PEA asystole. I will never get a cardiologist to cath someone that presented an asystole. Yeah, pretty confident that I'm never going to get someone to cath asystole. But when we look at the data, how often does asystole or a PEA actually have a coronary occlusion, i.e. could have an intervention by a cardiologist? 18% and 16%. 1 in 6 patients, right, that presented with PEA or asystole are actually having a heart attack. So we talked about our code blue patient, non-specific EKG changes, multiple rhythms. This patient, I could call my cardiologist. I know what they're going to say. Yeah, I'm not going to cath this patient. So then it's on me to figure out, well, okay, what's the next best thing for me to do to work this patient up? So the next steps that I'm taking is almost always a whole body CT. Debate, practice, variation, but I'm usually getting a CT of the head. I'm looking for things like subarachnoid hemorrhage. I'm looking for intraparenchymal hemorrhage, maybe a massive stroke, right, that led to hypoxia and some kind of arrest. Often we're getting a CT-PE protocol. We're looking for a PE that caused arrest. And then just for kicks, we throw in the abdomen because we can, I guess. Now, I'm not saying this is wrong. We find things on this scan. So in general, I'm an advocate of us, when they come in, we scan them from head to pelvis, just like our trauma patients. We call it a medical man scan. We find things. We find rib fractures, splenic lacerations. We might find a pneumothorax. We find a bunch of things. But how often do we find the actual cause of arrest? Not that often. When we look at just the PE study that we do on the chest, the yield of that in post-arrest patients is less than 5%. It turns out PEs don't kill that many people spontaneously in the community. Sometimes we do an aortic scan, looking for aortic dissection, less than 1%. It's just not that common. Meanwhile, we know what is common: coronary syndromes. And so this is where I think the future of cardiac arrest should go, is the use of what we're going to call a triple rule out CT. So a little bit more about what this is. This is a scan, a dedicated special type of scan that lets me see the aorta for aortic dissection, the pulmonary arteries for PEs, and super important, most important, is we get to basically do a cath on a CT scan. And so we can see an LAD with very good resolution. Now, this study was a huge trend in research 15 years ago and got dropped in live people presenting to the ER with chest pain. It turns out there weren't enough dissections or PEs to make this study useful. But now we're talking about cardiac arrest patients where we know there's a high prevalence of disease. Furthermore, let's talk about how we diagnose an acute arterial occlusion of the brain. An acute arterial occlusion of the brain, that's called a stroke. we get a CTA. Exact same thing. How do we diagnose a cold arm? We get a CTA of that arm. How do we diagnose an acute arterial occlusion of the pulmonary arteries, i.e. a PE? Same concept. We get a CTA of those arteries. Of the gut, acute mesenteric ischemia, we get a CTA. So my point here is, when we want to diagnose acute arterial occlusion of the coronary, what I think should be happening is we get a CTA, or triple rule out. That takes the diagnosis of acute coronary occlusion and puts it in the CT scanner rather than the cath lab. So our argument is that we have a high prevalence of disease. We're already scanning the heck out of all these people anyways. So why not do the scan that potentially has a higher yield? The image you get on cath lab is the exact same image you get on CT. It looks identical. We're going to find the VFib that needs intervention, and we're going to not cath the ones that are clean. VFib, clean coronary CTAs, they don't need to go to the cath lab. Alternatively, PEA, that 1 in 6 that does have a coronary occlusion, we're going to catch, and we're going to take that person to the cath lab. So I think there is a better way to diagnose ACS, or acute coronary thrombosis. I think it's CTA. What's the downside? Short answer is essentially none. Same contrast load. You have to do a respiratory pause. They can't breathe for 5 seconds. 10% more radiation, which in a dead person, I don't really care about at all. So what's the catch? It used to be heart rate control. We used to have to beta block a patient down to 65 beats per minute. That's impossible in a cardiac arrest patient. They all come in tacking away, right? New scanners, like the scanners at UK, 125. So we can catch tons of these patients. What's it look like? That's our CTA of an LAD occlusion. That's the cath lab image. It's identical. So what's the evidence? There's none. Hence it being a concept piece. Working with a couple different institutions to put this into an IRB and a research protocol. University of Washington has actually done some cool stuff this year, recently published 104 coronary CTAs in cardiac arrest patients, and they diagnosed ACS in 17%, which is about our PEA rate. Thanks for your guys' attention.
All right, since I got everybody sitting here, and since I'm off the free version, I want to tell you about some stuff that pisses me off. That's not really that bad, but some stuff that I see that I just like, oh my God, why do, number one, why do we do that? Number two, why do we insist on keeping doing it, despite the fact that it clearly is not helping? So, just a list of things. I'm not actually that broken up by them, and I'm not trying to insult anybody. I'm just saying things that are kind of controversial, get a rise out of everybody, but that's okay. All right, so let's talk real quick things that people insist on doing that don't really help in cardiac arrest. Number one, lots of epi, giving epi every 3 minutes. That's kind of silly. There's not a whole bunch of studies. There are 2 reasonable RCTs that show no benefit to giving a bunch of epi, at least in the way that we have done it. Now, everybody does it. It increases the chance you get ROSC. That's absolutely true. Like, if you give somebody epi, you increase the chance you get them to the hospital. You don't increase the chance you get them home, or if they ever go out and pay taxes again. So, is it worth it? Either you die in your house where you find them, or you die in the ICU. I'm not saying don't give epi. Some epi is probably helpful. A milligram every 3 minutes, or every 2.5 minutes, or every 2 minutes, not really helpful. Don't worry about that. The epi isn't really the thing that helps. 1 or 2 doses, but otherwise, good chest compressions, figuring out what killed them, and good airway management is probably the things that's going to help you. Number 2, bicarb. Bicarb's never the answer. The only time bicarb is the answer is when somebody gives you a test question that says, this person has a tricyclic antidepressant overdose. What should you do about it? Give them bicarb. Otherwise, bicarb is never the answer. It just doesn't help. And in fact, it can make people worse. So we get this idea that we want to treat acidosis with it. The acidosis just continues because they don't have any blood flow. You got to fix that first. It's usually not the acidosis that caused the arrest. It's the arrest that caused the acidosis, generally speaking. And the bicarb doesn't really treat the acidosis very much anyway in cardiac arrest. So bicarb, not really helpful. C-collars. Jesus. Tweet that. I've got an hour on why C-collars aren't really helpful. They're definitely not helpful in cardiac arrest. If you've arrested, you got bigger problems than your cervical spine. Also, C-collars have never actually been shown to help anybody. There's studies that show that they kind of keep your head from wiggling around, but not studies that show that they keep your spine from wiggling around. And in fact, when you put a C-collar on somebody, this study has been done. They take a cadaver, they cut its neck, give it a unstable cervical spine injury. When you put a properly fitting C-collar on them, it pulls their head off. It actually makes things worse. So C-collars, terrible. Its friend, manual inline stabilization. I'm going to hold his head still while you intubate him. You know what that does? Makes it harder to intubate him. Anesthesiologists actually looked at this, did a study on it, and they had to stop at about midway through the study because they were goosing too many people and didn't realize they had done it. That's like a never thing in anesthesia. But just by holding somebody's head in place, that thing was enough to say, it makes it that much harder to intubate them. And this is, again, good intubators, that much harder to intubate them and that much more likely that you're going to put the tube in the wrong spot and not realize it. So I hate manual inline stabilization. Yes, be careful of their spine. Don't wiggle it around too much, but you don't need to pin their head in one spot. I don't like naloxone in cardiac arrest. You're bagging them. You're already pushing on their chest. The naloxone really, its goal was to get the guy breathing again. He's not going to breathe again if he's in cardiac arrest. Give him the naloxone, that's only going to make him a little more agitated when he wakes up. No worries about giving naloxone in cardiac arrest. Yeah, it may not do something, but it's also something that you don't necessarily need to do. And if there's really no benefit to it, then ethically there's no reason that we should do it. One of the worst, or the thing that gets me the most, and only because it's been propagated out there, is the idea of dual sequential defibrillation. What happened here was somebody had the bright idea, hey, one defibrillator is not enough, let's try two. They put another set of pads on a person. They couldn't get out of VF, and they tried to shock him at the same time with both of them. They did not actually shock him at the same time with both defibrillators because you can't really do that. It's not. It's so precise that you're just not able to get your fingers to do that to line up. But that's the idea behind it. It's that if you have defibrillation, that usually, of course, the patient is laying on their back. We show up, we put a pad here and we put a pad here, and you shock across their heart, and hopefully that hits their heart. The idea behind dual sequential defibrillation is that you put on another set of pads. Maybe it's, kind of here and here if they're here and here. Maybe it's here and here, one way or the other, and then you try to shock them at the same time. And folks reported anecdotally that you got better outcomes with this. It seemed to terminate more ventricular fibrillation. The question has always been, is it that you're putting twice as much energy into them? Is it that you're phasing it differently? Like the shock is a little bit off, and so the biphasic thing, the wave and the thing didn't actually end up in the same spot, and so you depolarize more stuff? Or is it a different vector? The heart's just getting different energy for it. We don't know. Mostly because, is there any evidence for it? No. It's been looked at. The picture looks about the same. As I kind of said before, if you see these things, ultimately the line in the middle says there's no difference. If the lines on either side cross it, that means there's no statistical difference in it. Basically, if you look at all this, dual sequential defibrillation, when put into studies, doesn't help with neurological outcome, doesn't help with survival to hospital discharge, doesn't help with survival to hospital arrival, or, come on there, doesn't help with ROSC, and doesn't help actually terminate VF. And in fact, it's probably about the same. So there's this idea, somebody did it and they thought, this is really cool. And everybody else thought, oh, okay, that's really cool. We want to do that too. But there's not actually anything that shows that it actually works. When you actually take the anecdote part out of it and say, let's put this in the study, what you find is that it really doesn't make any difference. And if it does make a difference, it's probably more that you've now sandwich the heart between your pads instead of just skirting along the chest. So if you shock somebody from here to here, there's a good chance that a lot of that energy just goes right across the front of the chest and doesn't hit most of the heart. But if you put a pad here and here, i.e. right across the heart, there's a good chance that energy zooms through the heart and delivers a better defibrillating shock. What's the harm? Well, it takes 2 defibrillators. It's hard enough to get 1 defibrillator on a scene, but how about getting 2? You got to stop chest compressions to get another set of pads on. You got to stop whatever else you're doing for this thing that doesn't really seem to help. And then, yeah, is the shock itself harmful? I don't know. Nobody really knows because it doesn't really work. So there's no use in studying it. But what's the harm? It's that we're taking it away from doing the other stuff, the good chest compressions, the good airway management, the good pulse check, all that stuff. Those are the important things. What are the things that help you improve defibrillation? Good chest compressions, pulling your hands up off the chest with each chest compression. Maybe giving antiarrhythmics, lidocaine or amiodarone, something like that. Maybe at least it may not help survival, but at least it helps you to not fibrillate anymore. Or changing the vector, putting the pads in different spots. If you really want to get the benefit, I'll buy, all right, I haven't gotten anything here. He's still fibrillating. He's still squiggly, squiggly, squiggly the whole time. Okay, we'll just change maybe the placement of the pads instead of getting the whole new defibrillator. Pads are relatively cheap. Defibrillators are not. Take one, and if you got them here and here, okay, we'll now put them here and here and just see if that doesn't help. And I bet you it will. That's the better place to put it anyway. Things that don't really help, or at least cannot be meted out with data, dual sequential defibrillation. So, by the way, there were reports, one of the early people that did it, when they found 2 defibrillators, I think one was a physio and one was a Zoll, and they tried to do it both at the same time, and I think did it break the physio one, or did it break the Zoll one? It broke one of them, and it stopped working after that. And basically, the Zoll guys, if we ask Zoll specifically about it, they say, it's probably not going to make any difference because the thing can't really send and receive at the same time. But if you got 2 different brands and something, it's probably not going to hurt your monitor was the end result of it. But this one it did. So if you make that $30,000 mistake, depending on your monitor, make it a good one. Yeah. Oops. Okay. I got asked / ended up having to pinch hit the case review thing. The guy that we were going to have do it, who was unable to at kind of the last minute, is much better at this than I am. But I figured I would just kind of show you how I walk through a run. So this is a cardiac arrest run. It's not anybody you know. It may contain elements of patients that I have, or patients or charts that I've reviewed over time, but it is a chart that I made, so it's HIPAA compliant and all that kind of stuff. Should not be anything that you have to worry about, but just for fun, don't go spreading it around any place just in case somebody sees it and freaks out and stuff gets online and all that kind of stuff. But again, I made the chart, so don't worry about it. Here's what I'd like you to do. Take a few minutes and look at it. This is a cardiac arrest run. The goal at the end of this would be able to say, you call me in because I'm the paramedic that was on this run. How are you going to debrief me about it? And obviously, we'll figure out a way to do that. But just think about when you read this, what do you think about the run? What are the important parts of it? And then what would you say to the guy who was responsible for it? Cool? Yeah. Take, I said take, what, 5, 6, 7 minutes, something like that. And we'll get back in just a second. So, Abby and I were on this run. We've come in because we hear that you had something you wanted to talk about. So, anybody want to debrief me on this run? And you got to speak up because neither of us can hear very well. Yes, sir. Yep. Well, that's a good question. Did everybody hear that? So you got jump to the you got the big part of it anyway. So he noticed that our times seemed a little bit awkward and maybe don't line up with our tracings real well. In that 425, he said we saw asystole, or we said we saw asystole, whereas the tracing doesn't seem to show asystole. Like, well, Chief, I don't have a good answer for that one. I don't know. It was 4 o'clock in the morning, I guess. Yeah, I was pretty sure it was asystole the whole time.
What'd you say?
Woke him up from the rut so he could change it. Anything yet? Oh man. Well, don't I feel like an asshole? Man. Do you likewise feel like an asshole now?
Yep.
Yeah. Man.
I'd say I just drove.
Yeah, I know. It was ultimately my fault, man. I don't know. I was pretty sure it was asystole the whole time. I mean, I thought damn. Yeah. I don't know.
What is it? Am I suspected?
Yeah, I don't know. Yeah. Yeah, we intubated him pretty quick. We just
At 3:55.
yeah, we just put a mask on him, and then we did CPR, and I just jumped in there and snuck that in there. I think the time was pretty quick, right? Like I got him pretty early.
4:03. Yeah, 8 minutes.
Yeah, like eight minutes in. Yeah, I just yeah. No, I saw this thing at this conference about like not intubating people, so I didn't intubate him, or I didn't bag him because yeah. Man, I feel like a real jerk. We were on scene for an hour. That's right. 4 o'clock in the morning. We're on scene for an hour. Oh God. Man. No, we pulled him on the floor. Yeah. Oh yeah. Yeah, I may have forgot to put that in. But yeah, we pulled him on the floor. Man, I must be like a terrible paramedic. You must be a terrible EMT for letting me do that. Absolutely awful.
Terrible EMT for like you to scrub report.
Nobody else was signing up. Hey man, you signed it too. Yeah. What's up, man? Yeah, yeah. Well, the first time we were pretty quick to get it in, and after that we just kind of didn't for a while. We were doing like the intubation, I think, and the EMT usually does that. Epi. So why is there a little pause at the beginning and then 14 minutes between one dose of epi and the next one? We were just trying to think of like anything that could help him, you know, like nothing really seemed to be doing a whole bunch, and so we're just trying other stuff. I think our protocol is every 5 minutes. Man, I am a terrible paramedic. I couldn't hear you. I'm sorry. We put Untitled on him, I think. Yeah.
Yeah, sure.
We put Untitled on him.
Yeah.
Sometimes it doesn't. It may not have like shown up real well. Like we had it. Yeah. Yeah. The tube was in. Tube was in. Oh yeah. We had the Untitled. What'd you say? His blood sugar was okay. He doesn't have any diabetes. He doesn't have any diabetes or anything. Man, you're right though. I probably should have checked that. His wife said that he didn't take any medicine, so he probably wouldn't be like hypoglycemic, but man, I am a terrible paramedic. I'm surprised y'all let me work here still. Man, I don't know how I'm gonna go out and like treat a patient after this. This is pretty awful. Yeah, sure. ESO, sure. Oh, it's okay.
So you got started this rhythm at 4:03. Did you do anything?
I think that was a CPR one. That was just to mark for epi. That was when he was still getting CPR.
Okay.
Yeah.
If you look at the time at 4:06, you have an end time of 39. And if you match that up with the next closest EKG, it looks like you probably might have had a pulse back. Did you guys do a pulse check anytime in between there? Because that's
Where-
a pretty organized rhythm with the
Which one?
time.
We did a pulse check. Yeah. I mean, but if it was asystole, like we wouldn't have done anything with it.
But it wasn't a 6.
Well, I thought it was. I'll get you one second. Yeah, I mean, I guess it must have been. I don't know. There was a lot going on. There was like police on the scene and stuff, man. I just, you know. No, I mean, he was, you were able to bag him the whole time. You were bagging him the whole time. He could bag the whole time.
It was fine.
So on the Bible, we were talking about it. So it looks like this is like the monitor imported, but these are like
Yeah.
truly what a code vitals would look like.
Yeah.
Delete these all out and then just put the actual vitals in.
I mean, I don't know about that one. That's about 100, I guess. So. Yeah. That's probably when we did checks or something. Yeah.
So like they're like that. So you just delete these all out and you just put no pulse and then you would
Yeah,
put your
probably.
bagging or somewhere in there.
Yeah.
I don't know if we did this on purpose or it's fine.
Yeah, it was just what the monitor did. Man, Abby,
It was early in the morning.
it was early in the morning.
Shit. And you weren't feeling good that
No,
day.
I was not feeling. I'm not feeling good now.
I should have helped you out.
Son of a. I'm not sure where everybody else was on this.
Yeah. We really only worked here for 20 minutes.
We were there for an hour. I don't know. Okay. All right. Anybody else got anything they want to beat us up on? It was asystole. I'm pretty sure it was asystole. When all I can tell you is when I looked at the monitor, it would look like asystole to me. Oh. Whew. That's fair. Yeah, that's pretty. That is pretty shitty of y'all. Yeah. He said, so his point was, yeah, you should be able to see I don't have the sheet sitting in front of me. I mean, I could look at Abby's, but yeah. So good, excellent point. Like, if you are going to make the point, well, we keep saying asystole, asystole. I keep saying I thought it was asystole. Then it's really would behoove me to be able to be like, yes, here's the picture. Like it was not. And by the way, like sometimes it can, you know, how big is your LifePak screen? Like sometimes if you just glance at it, you could miss a beat in there. If it's a really bradycardic rhythm, if that little 6-second window or however long it is, if you don't catch it at the right time, you could miss like a slow PEA or something like that. Now, in this case, yeah, like we failed to capture that part. And this is, you know, this is not one case. Again, this is a made up case, but this happens all the time. I bring it up because I review cases that look like this all the time, that are like, they called it asystole and clearly there's beats. This is not a one-time thing. This is, the longer I stay at it, the more I've kind of seen it. Like, wow, okay, there's got to be some reason that happened. And that's really the thing that I think a lot of case review misses sometimes. Like, yeah, I missed it. I fucked up. But why did that happen? Was it that I couldn't, you know, it was really bradycardic and I just didn't look at the monitor close enough? Was it that I've been doing a 72-hour shift and I'm at the end of it and it's 4 o'clock in the morning and this guy seems to be dead? Could be something like that. Is there some kind of system reason that I missed that? Because yeah, I'm a paramedic. You're a paramedic. You can see that's not asystole. Yeah, we can all see that's not asystole, but yet people do it. People call it that all the time. So is there something? Is it a training issue? Is it our issue? Is it something in the service? Is there a reason that mistake happens? And that's one of the questions. One of the things I think about making case review kind of meaningful is that, you know, why did this happen? Not just like, okay, there was a protocol error, but like, was there something else? Did we give Versed instead of I'm trying to think of a Zofran or something like that? Did we give 10 times the dose of ketamine that we meant to? And if that's the case, is it something that's kind of the service's issue? Like we have 2 vials of ketamine, they both look exactly the same, but one says 500 milligrams and one says 100 milligrams in 10. Is that kind of our issue? I think we got to kind of look back at that when we see these things, these big misses. And sometimes, yeah, the guy just screws up. A lot of times there's a little something more to it and something we can kind of change in terms of our management to make it better. So don't forget, it's real easy to say like, and you know, as a medical director for a number of services, I absolutely do sit back and sit in my air-conditioned office. It's 72 degrees, it's well lit, and it's the middle of the day, and I can go get a cup of coffee if I want. Sometimes we just screw up. Sometimes there's a reason that we screw up. And if there's something we can put in place to kind of fix that or to help that, then that's probably worthwhile. And that's maybe something that doesn't come up in case review real often. Is there something else that happened? So also, it's everybody's been called into the office for something, I assume in your career at some point. Sucks, right? Sucks. Some things that can I see the run review? So some things that you might kind of note too. We did good chest compressions. Like if you look at the bigger file, they did chest compressions a lot of time. There's not a big pause in here. Like the vitals are a little funny, but from this guy's standpoint, they showed up, they intubated him real quick on the first attempt. They got an IV. The epi got a little, wonky in there for whatever reason. But for the most part, they did a good job, or it's supposed to be written as like they did a pretty good job of actually making the stuff happen. There were one kind of big mistake at the end of it, but try not to let, my recommendation would be try not to let the fact that you do 90% of the stuff right, make sure that we say that. Like, okay, yeah, I can look at the PCO file. Oh yeah, Jake, chest compressions look great on this one. You did the finger thoracostomy. You did the pericardiocentesis. You controlled hemorrhage. Did you realize that your dose of rock was, after you got him back, did you realize the dose of rock was 3 times what it should have been that you actually gave it? Yeah, like, that sucks if that's the message that you're taking away from it, because he probably thought, man, this was a great case. It was an excellent flight. We did really good. Me and my partner really knocked it out. And then you find out, oh crap, there's that one thing that gets you. Do make sure that you acknowledge the rest of it, because most of us are good people. Most of us know what we're doing and practice the right way most of the time, but we make mistakes. And if we let the mistake kind of be the biggest thing and that all that sticks in your mind, sometimes it can be a little much. Kind of turn bad people or good people away from an otherwise successful career if all you hear is the bad stuff. So don't forget that when you're doing case review.
So this is not going to be a long presentation out of the whole chunk of the day, but it's going to be a little bit more interactive than everything else, aside from you guys coming up here and doing all that jazz. So what we're going to talk about for a minute is resuscitation in a resource poor environment. So my first question is, how many of you all work at a service that if a cardiac arrest goes out, you're getting the fire department immediately and 2 or 3 people on a truck? Show me your hands. How many of you work at a department that if cardiac arrest goes out, it's you and your partner and you're praying to God one of the volunteers in your county heard it and meets you there? Can I get an amen on that one? Anybody? All right. So 6 months ago, I was working in Louisville where it was my partner and I was super fortunate because my partner was a paramedic student and she was awesome, right? So if we showed up, we're good. We know what we're doing. We've got this covered. We also were in the city of Louisville, so if cardiac arrest goes out, I've got at least 4 fire guys coming pretty freaking fast. Fast forward to now, I work in Henry County. My guys now are probably 15 to 30 minutes out after dispatch from getting on scene. And we're hoping that the fire department in that area has somebody that heard it and can get to a station and can meet us there. Or we're hoping that the sheriff's department or KSP, somebody's in the area, right? So the first thing we need to look at is what defines a resource poor environment, right? Pretty easy if you're talking about people. So if it's my partner and I that show up, we're gonna need some extra hands. So the way our department has kind of combat that issue, each of my trucks has a vent. We've got auto pulse. We have power load stretchers. So we're trying to give them all the tools that they may need, knowing that there's not a lot of personnel showing up. On the flip side of that, maybe you have all the people in the world, but you don't have vents. Maybe your life pack is super old. You don't have a Lucas or an auto pulse. So now we've got a different story, right? So what do we want to focus on if it's just 2 of us showing up? This is that interactive part. I'll stop and stare at you too. What do we want to, if it's just me and if Chris and I are the only 2 that show up, okay, we're gonna get some compressions going. What are you thinking about? What's going through your head at this point? Right? What might be on its way? And what if I'm listening to the radio and I'm not hearing anything? And we've called and radio dispatch says, I'm trying. I'll let you know if somebody pops up. Okay, how we're gonna get them out? Are we gonna get them out? But so something to think about, right? So now I need to start thinking about what's going on with this person. Let's look at the totality of all of it, right? So let's fast forward for a minute. We're now back in big city, and I have all the responders I can think of. Maybe too many. Anybody been on that scene where you got too many? Everybody's falling over each other. Everybody wants to help and do something. You're staring at me like, no, that doesn't happen. I get it. Some places that doesn't happen, right? But so maybe we've got all the help in the world and we're still trying to figure out what are we doing here? what I want you guys to start thinking about, and it's going to lead into Dr. Crowley's talk here in a few minutes, is what are the main things I need to work on? What's one of the biggest things that Walt's been talking about all morning that we've got to get done? Compressions, right? If I'm not doing compressions and I'm not doing good compressions, we might as well stop throwing the towel. So regardless of whether I have 8 people coming or 2, we've got to be doing good compressions. At what point in your all's practice do you stop and start thinking about, okay, am I working them on scene? Am I load and go, throwing them in the truck and screaming to the hospital? Or am I maybe making a call to stop this resuscitation? Okay, 20 minutes. Okay, so she says after we get our initial stuff done. So anybody work in a system where you're routinely calling the hospital for orders to stop? Routinely, as in occasionally, like that's what you do if they get to that point. What do they ask you when you call? I'm sorry? How long they've been down, right? How long they've been down? How long have you been working them? What have you done? What's that? And then what was the initial rhythm? So why does that matter? Okay. Okay, so I don't know if you guys could hear me. Said if they're in a systole the whole time, they can call them. So was there a change of rhythm? Did I get here and it was this and now it's not? They're going to want to know, how about Untitled? Anybody got a medical control that wants to know if you have a definitive airway? One last try. Let's see if we can get that in, right? So what Untitled range? What are we looking for? If it's under what do you think they're going to let us call it at? Less than 20. I've heard less than 10. I've had one told me we could call it at 22 because she'd been down for long enough. But these are the kind of things that you want to think about, right? So at some point we got to make the decision: are we going to keep working them? And like Jeff mentioned, 20 minutes. I think that's a good range, right? If we're taking into account how long they've been down, we're taking into account how long it took us to get there. Right? Maybe it only took you 3 minutes. You're right around the corner. Maybe you're in my county and it took you 30 minutes to get there and you were it. And the person that called was maybe doing so-so CPR. Does that change your outlook on things? So at some point, what we need to think about when that resuscitation in a resource poor environment is what resources do we have? And regardless of whether I have everything in the world that I want, all the toys and all the people, or whether it's, me and Gwen, at some point I have to decide, okay, are we going to take this in the truck and start running to the hospital with it? Are we going to work it here and then call it? And that takes into account everything, right? We need to take it because you're looking at, are we taking up a bed when we get to the hospital just to say that they're going to call it? Have we talked to family about what's going on? Are we taking our only truck, right? Maybe you're a county that runs one truck. If I'm working a cardiac arrest that we all know is not going to make it, am I taking that truck now 2 counties over to the next hospital just for show? So these are some things just to keep in mind when you're talking about resuscitation. It's not just work it, right? Obviously, Walt's been doing a great job telling you all how to work a successful cardiac arrest. And that's what we're here for, to learn, right? We want to save lives, but we also have to take into account that we can't save them all. And, when do we make that decision? So with that, I'm going to wrap up. Do you have any questions? I know it was a lot and quick, sorry. I talk fast. But so Dr. Charlotte Crowley is going to be next. And she is going to talk about when to terminate arrest in the field. So kind of give you guys some more guidelines, how that looks, what you all need to be thinking about when we make that step. And I don't
As Abby said, my name is Charlotte Crowley. I am talking about field termination, or how to stop transporting dead people to the hospital. There are a lot of different things to go into with this, but you'll see what I'm talking about in a minute. Just a little bit about me. I'm the assistant medical director at Anchorage Middletown over in Louisville. I did my residency at U of L, my emergency EMS fellowship at Buffalo. The Bills Mafia adopted me very lovingly. And I'm currently clinically at Southern Emergency Medical Specialists and affiliated with U of L. Objectives. We're going to discuss field termination, how to do it, some barriers to getting it done, and a little bit about the role of online medical control. This is basically just, we know this. We know the factors that positively impact your cardiac arrest outcome. Witnessed arrest, early CPR, early defibrillation, early return of spontaneous circulation, and being in that shockable rhythm to begin with. But for all the rest of the patients, I did go through the Kentucky state protocols. This is the most recent update. It is a paramedic level call with medical control approval to terminate efforts. It doesn't apply to trauma unless you see something after you start that is incompatible with life. After everything has been done, after all your relevant protocols have been followed, specifically the asystole protocol, if the patient is apneic and pulseless, fixed and dilated, and continues to be in asystole, then you are able to call for termination orders. All appropriate protocols includes advanced airway management and IV or IO access. In our protocols, there is no specific time frame given. There might be some locally, but and 20 minutes is just sort of the general gestalt around the country and even around the world. But there isn't a specific time frame in our protocols in the state of Kentucky. Whoop. Apparently not. Oh, there we go. So this is just the why, when, and how of ceasing resuscitative efforts. The bottom line is medical futility. All of these decision rules that I'm going to talk about have at the baseline, when the patient meets all of these criteria, there is a less than 1% chance that they are going to survive that situation, and that is considered medical futility. Once you have that patient that meets those criteria, you also consider things like resource utilization for your agency, for your personnel, your equipment, your time, and the hospitals as well, to be honest. Also provider safety. With use of lights and sirens becoming more obviously, higher risk than reward in a lot of cases, you got to think about where you're coming from, where you're going. Is it really going to help you to have to go code 3 like a bat out of hell with somebody that's essentially that is already dead in the back of your truck? And patient and family wishes, that can get a little muddy sometimes when there's not consensus between documentation and what the family is asking you to do. But overall, if there's a suggestion that the patient wouldn't want to be resuscitated any further, definitely a reason to consider stopping and consider calling your medical control. A couple of subjects that I'm not going to go into too much detail about because they're a little bit more complex and because there aren't really great rules for them. The first is traumatic cardiac arrest. It's not as well studied as the medical arrests. There are a lot of nuances in a traumatic arrest. Was it a blunt trauma? Was it a penetrating trauma? With the penetrating trauma, was it a gunshot wound or was it a stab wound? Those things affect the underlying cause of the cardiac arrest, the actual anatomy and physiology of why this person is arresting. There are suggestions that rural services need to have maybe a little bit more aggressive protocol with field termination of trauma patients, because if you're 30 minutes from the closest critical access hospital and 2 or 3 hours from a trauma center, there's nothing you can do to help that patient, essentially, no matter what you do, because getting them to a surgeon is really what's going to help, and you're not going to do that within a time frame that they're going to have any kind of meaningful survival. All that being said, the National Association of EMS Physicians and the American College of Surgeons in 2012 put out a position statement about traumatic cardiac arrest. They basically said, scoop and go. That's the way, that's the priority. They did say protocols should be in place. For traumatic arrest, they said that the protocols should be time bound. There was a previous version of the position statement that noted 15 minutes as the recommendation. That was removed. largely because after 15 minutes, you're already below that 1% chance of survival that gives you the definition of medical futility in that case. They also want you to have standard procedures for efforts for after the efforts are stopped, as far as who does what with the body, supporting the family on the scene if they're there. And the general idea with traumatic arrest termination is if after you have done everything that you can, whatever procedures are indicated, whether it be airway management, access, needle thoracotomy in some cases, including minimally interrupted CPR, if after all of that you have no signs of life, pupillary response, cardiac rhythm, spontaneous respiration, spontaneous movement, that's when you can consider termination of resuscitation. They say that the implementation of those protocols does require physician oversight. They say that they should specify that when the protocols do not apply. And they also say more helpful, which is kind of an opener. But there's that. The other one that is a little more complicated is the pediatric arrest. And you guys have a little bit, I think a little on pediatric arrest tomorrow. So I'm not going to get too far into the weeds, but overall, there's a slightly higher survival rate for pediatrics than adults in out-of-hospital cardiac arrest. And so you can't really apply the adult rules because the anatomy and physiology is just different enough in the tiny humans to make a difference. And it makes a difference in the cause of the arrest as well, because most of your pediatric arrests are respiratory in origin, as opposed to earlier he was saying, cardiac arrests are largely cardiac in origin in adults, particularly over the age of 45. Evidence in pediatric arrest is just harder to come by. It's just not something that is easy to study, and it's not something that is frequently studied. So the general approach is that unless they meet obvious death criteria or there is a DNR presented to you by family that is valid, you resuscitate the child to the best of your ability. There is no specific criteria or rule that you can use, but they encourage consultation early on with online medical control for these patients. So now this is the sort of the bulk of it. There are multiple termination rules for adult medical out-of-hospital cardiac arrest that have been developed over the last 15 to 20 years in particular. They apply to multiple levels of care. There are some common elements to these rules, and I'll go over those in a minute. There are other proposed additions to these rules that affect the statistical outcomes. They affect the sensitivity and specificity, your false positives, your false negatives. And I'll mention some of the possible included criteria to you in a little bit. With new technologies, particularly with paramedic ultrasound in the field, and the presence of more physicians in the field doing things like that, these criteria may change pretty significantly in the next little bit. But if that's not something that your agency is doing, the rest of these rules are applied to any level of care, to any level of technology, basically. They do caution being careful with non-cardiac causes, your drownings, your hypothermia, your lightning strikes, definite ODs, things like that, where presumed cardiac is not the box that you check on your little CARES form on your PCR. There are two sort of internationally known termination rules. The first one, known as a universal rule, is a BLS rule. It applies to all levels of care in the pre-hospital setting. If a patient has received all available interventions at whatever level of care is available to them, and they were not a witness, not an EMS witness arrest, so bystander witness arrests do fall into this category. If they never received any shock from an AED or a monitor defibrillator, and they have not had any return of spontaneous circulation, then it is time to consider that they are medically not savable and consider termination of resuscitation on these patients. The ALS rule adds just a couple of things. It adds that the arrest cannot have been witnessed by anyone, and nobody has done bystander CPR on the patient. So it actually expands the number of patients that you're potentially transporting or not terminating, because it is more narrow. Fewer patients meet those criteria. Sorry, I can make sentences. The other proposed elements, and these are all probably with the studies that I was looking at were within the last 5 to 6 years. Looking at, did the patient have a rhythm change from something unshockable to something shockable? Was the initial rhythm unshockable without any regard to the later rhythms in the arrest? Was the initial rhythm asystole in particular, as opposed to a PEA or just this unknown unshockable rhythm? What's the patient's age? And that one is combined often with a subset of other factors. So there's one in particular that says age greater than 80. Then there's another one that says age greater than 60 if their presenting rhythm was asystole. There's another one that basically it says age greater than 18, but that's only to specify that it's an adult rule and not to be used in pediatrics, but that's kind of a given for all of them. Presumed cause of the arrest plays into some of the rules, and specific timeframes anywhere from 10, 15 to 20 minutes, again, with the caveats of being associated with other criteria that are used in those rules. The NAEMSP did put out another position statement in 2011, actually before the first one, that TOR protocols need to be in place, including procedures for what to do after you're done and how to support the family through the immediate post-arrest period. They reiterate the BLS rule criteria and say we need a little more research on time frame and on whether online medical control is necessarily needed for the yes or no. They do say that implementation of the protocols, developing the protocols needs physician oversight. And they also, like with the trauma, say field termination protocols will not always apply, and we need to know when those cases are. And that's, that presumed non-cardiac causes sort of situation. So when you wind up with an arrest and you use whatever rules that you're using, you end up at a decision point of, okay, let's make this call. You make the call, you're done. This, to me, it's only one slide, but it is very, very, very exciting. More field termination. If your agency is doing a higher rate of termination in the field, that does not equate with your survival numbers going down. And most importantly, it seems like it's actually starting to be associated with a higher rate of favorable neurologic outcomes. So of the people that we're saving, we're doing better jobs for them and getting them out of the hospital on their own 2 feet, as opposed to becoming a vegetable in a skilled nursing facility. And that to me is just so exciting. I'm very nerdy. So in areas with rates of higher field termination, there is a relationship. They don't have any change to ROSCTOB hospital arrival. They don't have any significant change in survival to hospital discharge, but those patients who are making it to discharge are doing better overall. There is a correlation with longer on scene times, whether it's A causing B or B causing A, or just, the amalgamation of all of the factors. The suggestion that these studies are making is longer on scene times lead to better outcomes. And that's making it, particularly in the urban areas that have been studied, is moving a patient during the resuscitation detrimental to their survival. And that is something that is seemingly, yes. And it makes sense because you're not doing as high quality CPR when you're moving the patient on a stretcher, when you're in a moving ambulance, even with a Lucas and autopulse, any other mechanical device. You're just not getting as high of a compression quality as you would be previously, or as you would be if you were staying on the floor wherever you are. So yeah, that's my nerdy thing that I'm really excited about. Now that we kind of have talked a little bit about how, there are a lot of barriers to actually putting the theory into practice. There are a lot of different ways to address them. As with anything in quality improvement in EMS, there's patient factors, provider factors, and system factors. For us, the provider factors, in a lot of cases, you've got the sort of more intrinsic ones where this is unfamiliar territory for a lot of people. Particularly veteran medics who did not come up in an era of stay and play, when put patient on stretcher, put foot on gas pedal was the only thing you needed to do. If that's what you learned, it's hard to learn otherwise. And it can make you uncomfortable having to talk to somebody about their loved one being dead on scene. So there are lots of different training models for how to deal with the death notification. One of them in particular that I've seen in use is the grieving mnemonic. I don't know if that's what you guys are going to go over tomorrow or not, but there are other training, other models of training in how to relate to the family during the transition of patient alive, now patient dead. Now you have to start treating the family as well. Hopefully not because they pass out in front of you, but that's neither here nor there. The sort of extrinsic provider factors are a little bit more of the legal issues, the scope of practice issues. This is a little bit of me pontificating, but it's sort of evidence-based pontificating, so I think it's okay. Should AEMTs or EMTs be able to call for medical control to terminate resuscitation when we have rules that are validated and that were derived and validated at a BLS level? Particularly because in Kentucky, online medical control is required. These are things to be addressed at, they're not addressed at the provider level, but they affect us at the provider level. They have to be addressed at the local, state, regional levels, just depending on what the specifics of the legal terms, the legal wording is. The patient factors, you have the factors about the individual patient during the arrest itself. Is this patient that just will not get out of VFib? No matter what you do, you've shocked them 6 times, you've shocked them 12 times, you can't get them to do a dang thing other than just, or is it that one that you get a pulse back for 2 minutes, then it's gone for 2 minutes, and you get a pulse for 2 minutes, and then it's gone for 2 minutes? Are they in that pseudo PEA where they're just in profound shock, but if you had an ultrasound probe to put on, they'd be having this nice, beautiful, organized cardiac activity? The development of specific protocols for those situations is a little difficult because there's no way to develop a protocol for absolutely everything that you're going to encounter. But encouraging online medical control consultation with these patients earlier on, as opposed to just continuing to wait and go through your algorithms over and over and over and over and over again, is another way to potentially address that that hesitancy to terminate resuscitation. And in a lot of areas, EMS physicians are, and particularly online medical control, EMS medical directors, we want to do this. This is something that we chose. This is a path that we wanted to take a part in. And so we want to be involved in these decisions. I love being involved in these conversations with paramedics, with anybody on the scene, just to say, okay, where do we go now? Another thing about the patients, the younger they are, the harder it is to stop. That's just very plain and simple fact, particularly if they're the actual pediatric patients. Logic kind of goes out the window with pediatrics, so you have to like collect yourself and make sure, okay, we're going to do this right. But there are actually specific training protocol or training devices and protocols and processes to deal with pediatric death in the field that actually increase or improve the relationships between EMS and families. They improve the relationships between EMS and the family and the general medical establishment. They're just really good for community relations in situations where you have a pediatric arrest. And then you've got the family members, which I put this sort of as a patient factor, but it's kind of a system factor, where you've got the family members who are just begging you to do everything, even though the patient has documentation that says no. I have actually been called on the phone and on the radio for these kinds of cases and talked to family members myself. Get your medical control online for these, because we have to think about what's right for the patient, not just what the family's asking us to do. Because if the patient signed the DNR paperwork, that's what the patient wanted. And again, this is kind of pontificating, but again, it's important parts of the process. And also letting the family see that process. CPR is absolutely brutal if you've never seen it in real life before. And having them witness the efforts and be a part of that conversation about what's going on, what's the likelihood of survival, may help them to see what's actually right for their loved one, and let their loved one die at home as opposed to under the harsh fluorescent lights of a hospital. And then you have the sort of system and community factors. When you don't have enough medics to make every cardiac arrest, should we as a state think about expanding the protocol to other levels of care? Again, I know I've said that before, and that's something that I clearly have an opinion about, but that's just one of the system factors that plays in, and that it may not be as relevant in places where other levels of care have the ability to contact medical control for termination. There's also areas, particularly some of the rural areas that I've worked in, where there's not really a readily available physician for online medical control. And this is not on the EMS establishment to fix. This is on, I think, the emergency medicine establishment as a whole to say, okay, how can we educate people right before they go out into the community that they may be called upon to do this, and we need to do this in an evidence-based fashion. You know, stick a binder next to the radio at the base station hospital, those kinds of things. But again, that's on us. That's not on you. There's also the expectation of the lay public that you are going to pick somebody up, do some chest compressions, and rock it to the hospital as fast as you can. When Buffalo transitioned from a pretty standard approach to the do not transport unless you have ROSC, unless the safety of your crew is in jeopardy approach, they had to do a big PR blitz. They went on TV, they went to the local newspaper, social media to say, you're gonna see some changes in EMS locally. You're going to see us on scene longer. That's because we're doing the right thing medically for your loved ones. And overall, it actually went over pretty well. And the numbers, Buffalo is one of the places where the numbers are looking good as far as neurologic survival. Just a very brief bit about the role of online medical control. A lot of people treat it as just a yes or a no. Yes, you're okay to stop resuscitation, or no, keep going. But it's so much, it can be a lot more than that. Like I said earlier, this is something that a lot of medical directors and emergency medicine residents, these people, we want to be a part of this process. So call when the protocol says so. Call when you need some extra brain power, just a fresh perspective. Do we tell, maybe we'll tell you to do change the vector on the pads. We will not tell you to do dual sequential because that's garbage. I thought that before today, I promise. Maybe we know that you have some drugs on your truck that aren't in your algorithms that we tell you to give. We just have again, a fresh perspective, a fresh set of ears to hear the situation and maybe notice something that you didn't. Conflict on scene is another big one. And this is, again, where I was talking about getting us to talk to the family. Obviously not the kind of conflict that needs a police. In that case, go. Your safety is not worth risking. Your safety is not worth the sticking around. Y'all know what I'm saying. Your safety is important to me. So these are just, again, that's just the references. But my fellowship director in Buffalo used to always end talks with tossing a grenade and running away. So these are just a few things that I think it's important for us to think about when we're talking about termination of resuscitation and out of hospital cardiac arrest in general. Our goal here should not be ROSC, because ROSC doesn't mean much if somebody's coming out of vegetable. Our goal should, and these are entirely pontificating. This is not to be, there's no official opinion of Anchorage, of Cincinnati, of anybody, but just stuff to think about. Is our hands are tied of resuscitation or transportation the wrong thing to do? When they don't have the valid EMS DNR, but they have all the other paperwork and the family's just saying, please stop. She wants to die at home. He didn't want this. Is it the right thing to do to stop? Can you justify it? Absolutely, in my personal opinion. And currently in the Kentucky protocols, it's ASYS. The next two are potentially expanding protocols. Currently in Kentucky, it's asystole. But if you've got an 85-year-old person who's been in PEA for 20 minutes, they're Untitled 6, their rate on the monitor is only 30. Are you going to get that person back with any kind of meaningful recovery? No. But because they're not in asystole, that our protocols do not apply. Should we consider maybe expanding that? And then again, expanding to other levels of care because you're already talking to the doc anyway. So why can an EMT or an AEMT not also talk to the doctor and get the approval? Can you get the right information from a BLS level of care? And absolutely you can, because the BLS rule is just no shocks, no EMS witness, and no ROSC. And the last one has not a lot to do with field termination, but it's my baby. It's something that I'm really interested in, is can we prevent some of the EMS witness cardiac arrests if we stay on scene longer with the sick crashing patient to say, let's use our brains, our skills, our training to keep from having the, she coded it in the stair chair, Brian, how do you think it went conversation? So that is my presentation. Questions, comments, snide remarks, welcome.
Well, so I'll get started. My name is John Osterman. I know some of you. I work as a critical care paramedic and educator now at Georgetown Scott County EMS and Baptist Health in Lexington. But I'm not here for them today. So I'm part of the Kentucky Pre-Hospital Education Collective. I don't know, whatever we are. Yeah. So I'm one of the planners and organizers, and I enjoyed this stuff. So excited you're here. I hope this is meeting all of your expectations. I have 2 airway talks. They're going to go kind of back to back. And so the first one is 5 things to make your next airway attempt better. Looking at the people I know, we've got, I think, every level here. I don't know if anyone's in advanced, but I know we've got medics and EMTs and flight medics. So, like, we got some experience. I hope everyone gets stuff out of this. I felt kind of funny putting it together because I felt like it was kind of like repetitive stuff that, like, duh, we already know this. But it matters, right? And I think it's good reminders for anything else. So when we start thinking about airway attempts, I like to try and think, how can this apply in other settings, right? So we're here in a brewery, right? Let's talk about how they make their like, how do they get this gorgeous stuff in the glass for us? They get together, they have planning meetings, they decide what we're gonna make in 2022, they decide a timeline, they assign roles, they have tasks. Someone actually does the work. They have a quality control process, a review, and then they reflect on sales, right? Sales is a great QA process. And then they plan the next cycle. So thanks for coming to my talk. No, so that works for beer manufacturing. My wife owns a food business. We have a very similar model in her food business. And I think we can just keep kind of copy pasting and not reinventing the wheel into airway management. So there's 5 things I want to focus on. I want to talk about planning, positioning, pre-oxygenating, practicing, and reflecting. So I think all 5 components we need to do to be successful in our next attempt. So the first one, planning. All right. So when I first start thinking about planning, the first thing that pops to my mind, and I don't know if it works for you all as well, is at the patient's side, when I have the laryngoscope in my hand, I'm sharing my plan. And that's a good time to plan. Kind of the picture on my right or your left with the planning, right? We're going to plan at the patient side. We're going to assign roles, stop points, and go with it. But I think really planning should start earlier than that. If we looked at the picture on your right, the coffee table, hanging out in the kitchen in the morning, let's start planning then. Hey, so I'm with Nick. We don't normally work together. While we're going through the truck, hey, so if we get a code today, do you want the airway? You want me to do the airway? You'll take the airway? All right, cool, man. So you'll get the airway. I'll do everything to set you up. I'll keep an eye on the monitor. When do you want me to tell you to stop if you're not successful? Okay, cool. I like that. I kind of lean the other way and just like, let's anticipate when to tell me to stop. And that's an important thing when we think about the plan is we got to set stop points. Have we all seen that medic, or if you're an ER person, that doc who is hell bent on intubating the patient, pulse ox level be damned, right? We're like, cool, doc, you got the tube. They're assuming room oxygen saturation at this point, but you got the tube. Way to go. Can we start compressions now? We need stop points set. I'm going to talk more about oxygenation when we get to that, but setting stop points, assigning roles. Hey, Nick, you're going to be the intubator. I'll set you up. I'll be your assistant. And Joe, you're gonna watch the monitor for us and tell us when we're at 90% on our pulse ox or if our rhythm change. Everyone cool? Cool. All right. So planning includes role assignments, the stop points, and then setting up our plan. So when we start thinking about our plan, we should determine, hey, so what's plan A? Are we going into tracheal intubation? Is that in our skill set? A BLS staff truck, you can still do this. Hey, plan A, IJO, right? Plan B, we just leave some OPA, MPA, bag them, call, hopefully ALS gets there soon, right? We can still plan as a BLS crew. It doesn't have to be a medic only, doctor only type of thing. So knowing our plan, knowing our devices, knowing our equipment, and then when I start thinking about other industries that plans really matter, everyone's flown, right? You think there's a plan in place before you hop on the airplane and just take off? God, I hope so. Some flights, but most of them, right? There's some sort of a plan that you assume the pilots and co-pilot and crew have briefed each other. They set up, this is what we're doing. If we have a problem, this is what we do, right? I think we should be doing that as well. Nonverbal things really help. We're all humans, and humans have this weird tendency that in stress, we do dumb things, right? And we revert back to our training. So how do we do in school, our initial paramedic school, EMT school? How do we do with our initial training? Everything's kind of like lackadaisical. We just kind of do gross motor movements, whatever. I think our planning needs to account for all of that, and a plan for us to do dumb human things, because most of us are probably on the dumb human side of life, myself. All right. So here, I found this great resource. I didn't make this. I wish I had. I would have like copyrighted it and sold it for $1 gajillion. These kind of plans, this is from KI Docs. They, I think down in, gosh, I want to say they're New Zealand, and I'm probably totally wrong. They came up with this. This is like a 4th generation of this plan, but in their ERs, they have this as a laminated like table thing. It sits on their airway cart, and as they set up to do an intubation, they set the stuff on the shadows of the stuff, right? So like your bougie always lies on the bougie line. Their BVM's already over here, nasal prongs, whatever. Everything's laid out on purpose with a plan that if we need it, we know it's always here. The bougie should always be on that gray area between the plan B and plan A setup, right? I know many of you are firefighters. Everything on the truck goes back to the same spot every time, right? It's supposed to? All right, there we go. So we try to position everything the same way, the same time, every time, so that when we need it, we don't need to use as much of our brain to get the thing, because it's always where it should be. So this all goes back to planning. When we take the time to invest in planning, we don't have to use as much brain power when we have a sick person in front of us, remembering, okay, well, I need this, and I need that, and I need this other thing. Because if it's the habit that it's always there, then it's always there. That makes sense? All right, so planning, super important. Leads into the next thing, let's practice. So I asked my medical director and an anesthesiologist friend just for kind of some of their input of when they practiced residency, anesthesia, they're like the experts of the airway. Did they ever duct tape a mannequin upside down under a table? The answer is like, no, that's stupid. So you're all EMS workers. Who's done the intubation rodeo with the mannequin duct taped upside down under the table? Few of us. Okay. Does that correlate to real life at all? Pretty weak sauce, right? Let's practice the things we really do in the places we really do them. Let's put the mannequin in the back of the truck. Let's not leave the mannequin on the table. Let's have the mannequin on the floor in a brewery and do the stuff we would do on the floor in a brewery. Not on the table, in the back of the truck, on the floor where we'd find them. If we're intubating people that are trapped in something upside down, and that's the situation we're in, I don't think we should be intubating them. I know that's not a popular thought. I think we should, when we do endotracheal intubation, it should be optimized to be the best attempt of the first time. There's literature that every attempt we are far less likely as the attempts add up to be successful. Let's make sure we're successful the first time. Does that make sense? So I'm trying not to get feedbacky. So practice how we're actually going to do the work, where we're actually going to do the work, with the stuff we're actually going to use. That's another big pet peeve is our training systems. The kit we use should be very similar to the kit that's on the truck, right? If you're in a shop that does video laryngoscopy, you got VL on all your trucks. In training, you shouldn't be doing anything but, well, I mean, you should use what you're going to use, right? So you should maintain your direct laryngoscopy skills, but you should also be doing video laryngoscopy in training with the same device you have. So since Stryker's here. So if you're using the McGraths on all your trucks, you should have a McGrath in the training setting too, right? That way when the first time you pick it up isn't the first time you've picked it up in months. Because that's the thing too. This is a decaying skill. If we don't regularly practice airway maneuvers, we lose our airway maneuver skill, right? I'm sure a few people may have encountered that once or twice, that if you don't do it, you lose it. So we don't do a lot of advanced airway stuff. The things we do, we need to be really good at. And going back to dumb human tricks, we should also plan for our dumb human brains to sneak up and sabotage us every now and then. I'm a huge fan of offloading decision-making to cognitive tools that I've spent really hard time thinking about planning. Plan for problems, make checklists, make flashcards, like trial things so that when dumb things happen, you don't have to like be a genius about stuff. You can already have the plan made, right? There's a popular saying about doing a crike that the hardest part of doing a crike is making the decision to do a crike. Because if you're, especially the surgical crike, it's a cut, it's something goes in the hole. The psychological decision to make the cut, that's the really hard thing. So plan for hard things, plan for your brain to do dumb stuff, make flashcards. This comes from Sydney Hems. This is free on their website. So Sydney, like, Australia, HEMS. These are free. They have a couple others as well. They fly doc medic flight teams. So the knowledge level of the people on the truck, you'd think a doc and a medic should be able to work through everything and not need flashcards. And I'm sure they probably do. These aren't the idiot's guide to problem solving. These are the expert's guide to, hey, dummy, don't forget this thing. Does that make sense? Does anyone implement any stuff like this already? I know a lot of the flight systems, you guys have the the badge buddies for RSI. But what about like ventilator alarm things? I know these are ventilator alarm things. Yeah, you guys got vent alarm cards too? I found this, and like there's a really rough draft that I've got going for my shop. So like I really like offloading tools. I do think we should know by memory how to do this stuff, but I don't think we should rely on our memory. Going back to aviation, I'm certain a pilot in a plane knows how to get the plane off the ground and to where they're going. Do they still run a checklist? They absolutely still run a checklist because humans do dumb human things and it's real easy to forget stuff. Let's plan for dumb human things to happen. Let's practice our tools so that we don't have dumb human things happen. So we've got plan, we've got practice, how we play, where we play, and what we play with. The next thing, pre-oxygenate. So this is probably like a shudder-inducing kind of graph, right? It flashbacks to medic school. We start thinking oxygen disassociation curves and weird crap like that. Yeah, Abby, that's the right reaction. Gag, puke. This is a thing, and we should be mindful of it. When we pre-oxygenate our patients, our goal is to get their pulse ox as high as possible. I know normally we don't like hyperoxia, but in the airway management time when we're going to stop ventilating someone, we need to set ourselves up so that we get the longest amount of apnea. Because, well, oxygenation is kind of a big deal, right? COVID's definitely shown us that some weird things can happen, but this is really important because we don't measure PaO2 in the field. Unless you have iStats and you're like doing regular ABGs or epochs or I don't know, some cool fancy stuff like that, we're not measuring a PaO2. We do generally measure SpO2, right? Our pulse ox finger probe. So we have an idea of about how saturated their hemoglobin is. Well, there's this correlation. So SpO2 and PaO2, if you look at the graph, at a pulse ox of 90, your PaO2 correlates in most population to 60. So your normal ranges for PaO2 are kind of like your normal ranges for SpO2, like 90s are good, 60s kind of getting to raise your eyebrows a little bit. And then if you remember how the oxyhemoglobin curve goes, or you just look at the graph, after about 90, we start getting like this steep deceleration. Like this would be a great Cedar Point ride, not a great oxygen ride. We drop our saturation from 90 to 75 and our PaO2 goes from 60 to 40. That's not awesome. So this is where pre-oxygenation really sets us up for success. The better we pre-oxygenate our patients, the more time we have to do the work we need to do without them decelerating into like this awful death spiral where they die and we go, huh, that's weird, but it's us that causes it. So pre-oxygenate BVM before with a nasal cannula underneath. Everyone familiar with this? This isn't a super new concept. The whole apneic oxygenation thing broke my brain when I realized, like someone had to say, hey, John, do you think you're still oxygenating when you exhale? Like if you blow out all your air and hold your breath, have you stopped oxygenating? And I was like, well, no, I guess not. That same kind of principle is at work when we're doing this pre-oxygenation. See, oxygenation isn't ventilation, right? Two separate concepts. As long as there's more oxygen in your lung and your alveoli than there is in the blood, oxygen's moving across your alveolar membrane and onto the hemoglobin. Does that make sense? Am I beating a dead horse? We all got that? All right. So if we put this nasal prongs on, we crank that sucker up to 15 and let it run until we have a tube in their airway. We're going to keep oxygenating even though we've stopped ventilating the patient, which buys us more time to do the work we need to do and hopefully prevents the patient from going to hypoxic cardiac arrest. So plan, practice, pre-oxygenate, position our patients. This is one that we struggle with. So going back to the upside down patient might not be the best position for the patient. How many of us learned they're always on the table, right? We learn our innovation skills, our advanced airway skills, they're on a table. And what do we do with the head of the mannequin? We just try and rip that thing off by the chin, right? You all know what I'm talking about. Kind of that thing. So, and we call it the sniffing position. I've never handed my wife flowers and said, "Here, smell these," and she's never gone, "Yeah, they smell great." No, it's not how. No. So microphones are cool. All right. So when we think sniffing position, let's change some letters. Let's call it sipping position. So I'm willing to demonstrate with you all, my esteemed colleagues, the sipping position, right? And then if you need from this angle, how often do you do a conference in a brewery and get to drink beer during your presentation? That's awesome. All right. So this position, head forward. Scott Weingart, EM doc, I think in New York, talks about in one of his training videos, you got to have your ear hole in line with your neck hole. So the tragus or your ear in line with your suprasternal notch on that same plane really helps. It makes it a lot easier when you do your laryngoscopy, video or direct, to lift the jaw up or see around the corner and get success on your first attempt. So positioning super important. Other things, you can do some extra laryngeal manipulation. We used to call it cricoid pressure. Cricoid pressure, not that great. It's pretty indiscriminate in how we were using it. We should be a lot more precise, maybe even involve a second set of hands and kind of do like a, you know, that scene from Ghost where he's helping her make the body, do the kind of same hand-on-hand thing to maneuver the larynx till it's where the intubator wants to see it and then the assistant knows where to keep their hand. That's really helpful if you're having a hard time and need to do some glottic maneuvering. There's this great resource out there called the Vortex approach. I don't know if anyone's heard of that. It's another, either Australia or England came up with this model, but basically it goes back to planning, practicing, setting yourself up for success. There's a vortex where we lose track of time and attention the harder something is. And using their approach, you should maybe not have as poor of outcomes when you lose track of time. And then the last one I have is reflecting, right? So my name's John, I'm a human, I'm a paramedic, and I've made mistakes. And because of those mistakes, I've been able to change my practice so that the next time I didn't make the same mistake. I know, Steve, I'm a disappointment. I don't think we learn, I don't think we get better if we don't admit we've made mistakes. If we can't admit to ourselves at least that we've made a mistake or not done something optimally, then we can't change the thing that we did wrong and get better for the next time. And if we can't get better the next time, we keep doing the same mistake over and over and over and over, and we just go, huh, that's weird. I'd rather we break that cycle, and reflection is how we do it. Objective feedback from peers. If you're doing the video laryngoscope thing, if you can video record it and then watch your attempts, that's code debriefs. I know Walt and Abby did a debrief earlier today. Those debriefs are crucial. I know it, to go a little sideways, at my shop, we have the Life Pack 15s from Stryker. Right? Yeah, okay. So we have the Life Packs, and we have the events programmed into all of our Life Packs. And we were asking crew members like why they weren't using the event markers, because it's really easy to, instead of having to like guess when you gave drugs, just push the thing. And they're like, well, it's not set up uniformly across all of our things, all of our monitors. Without that bit of reflection and asking why they're not doing stuff, we didn't know there was a problem. We lost track of 10, 12 monitors, not all having the events in the same exact order. So because we reflected, we get this feedback, we changed things. We got everyone's feedback, and then we went and put in a standardized list on all of our monitors. They're all the same. No matter which one you pick up, you hit the event button, the columns, the things are all the same. If we don't reflect when things go good, we don't know how to repeat the things that went good. If we don't reflect when things went not so good, we don't know what things we can improve. Sometimes the problem is the patient. Sometimes they have weird anatomy. I guarantee there aren't nearly as many anterior airways as we say there are. It's just we're not reflecting and changing based on our previous practice. Does that make sense? So that's 5 things you can do to change your next airway attempt. Plan, practice, reoxygenate, position, and reflect. It's like a pterodactyl. All right, so there you go. I was going a little alliteration. You got to be able to do these things. That's what's going to make us successful in any of our airway attempts on any level, whether we're looking at BLS level, medics, flight medics, docs, RSI, surgical airways. If we can't reflect, we can't practice, we can't plan, we don't have clearly assigned roles, we don't optimize our patients, we're not going to be successful. Our patients kind of count on us doing these things so that we're successful. Could we do this? Is this doable? Yes? Yes? All right, cool. All right, any comments, questions, concerns about 5 things to make your airways better? All right. All right, is everybody ready to go? Just a minute? All right, cool. So just while we're getting started, who doesn't interact with ventilators like maybe once a month? Yeah, except that retired guy. So everyone does some kind of interaction with a ventilator at least like once a month-ish. If you don't, you could still get stuff out of this. If you're an expert in ventilators, correct me if I'm wrong on stuff, because this is an interesting kind of talk. Sorry, guys. I'm too hot. All right, so ventilators in 20 minutes, right? This is our last kind of group talk like this. I get to kind of close this out. After this, we have 2 workshops and we're done. Then we hang out and then we drink. Wait, we're already drinking. Then we drink more? I don't know. Eat? Whatever. So ventilators in 20 minutes. This should be a fairly introductory talk, but I want to just share some stuff. So I'm a big fan of vents, and there's a lot of ventilator options out there. You have some really basic ones. Anyone carry like the AutoVent 3000 still? Have we like cast that thing into hell? What? What? Okay, well, I guess it's not all the way there yet. So there's really simple ventilators like the AutoVent 3000. That's what, like 3 dials? Yep. Hey, if it works, it's not awful. It could be, I don't know. So my shop, we are transitioning from the Parapacks to the to a different manufacturer's device. It's not Stryker, so I don't want to represent them because they're not here sponsoring our conference. So we're transitioning to a different device. But because ventilators all are so different, it was hard to like grab a ventilator to use for screenshots. So we came up with John's kind of very, very basic ventilator. Everyone can read that okay? Looks like not everything turned colors like it was supposed to. So there's some kind of fundamental settings all ventilators are going to have, right? You're going to have a tidal volume. You're going to have a respiratory rate or breaths per minute. You're going to have a FiO2. Hopefully you have an FiO2. That's, I guess, a little more advanced. And then you're going to have a PEEP setting, and then maybe some different modes, right? So we're going to use John's garbage ventilator here just to kind of go over some settings. So when it comes to using a vent, when would we want to use it? Well, definitely intubated folks. Eye gels, any advanced airways, you could use them on trachs. Could you use vent to like oxygen, like as a lazy BVM? I guess I wouldn't, because you don't got a lot of like feel on compliance and like airway management if you don't have an advanced airway in. But like, So it looks like it's just going to be advanced airway, folks. Should we agree with that? So how do we go about setting it up? I have a friend who flies, and he's an educator, and he's got like this really great saying that I match the requirements every time. It's a mnemonic. And it's a pretty good setup of where first we want to figure out the ideal body weight for the patient. So ideal body weight. So how would you guys, if you had to set up an event, how are you going to go about setting up or estimating the patient's ideal body weight? We're going to channel our inner carny and guess how tall they are, right? Sorry if that was disrespectful to carnies. Sorry, it's all Walt's fault. All right, so we're going to guess their height. And what do we do with their height? Everyone's favorite thing is what we're going to do. We're going to do math. So if it's a man, we're going to take their inches in height over 5 feet tall, so greater than 60 inches. We're going to take that number of inches, we're going to multiply it by 2.3, and we're going to add it to 50. If it's a woman, we'll do the same inches over 60, multiply it by 2.3, add it at 45.5. So everyone's got that. We're ready to do some math. No, good, because we've been drinking. Let's not do math. How about we use a table? How about there's a QR code. If you want your own copy of the table, you can download it. We use this at my shop. And the center column is where we start. It's got their height in inches. The first red box is 5 feet tall. The second red box is 6 feet tall. So you would guess their height in inches. Friends from Stryker, how long is the mattress on your cot? 84 inches, 81 inches. All right, so if you have a Stryker branded cot and the patient is as long as the mattress, 81 inches tall. How about that? You could also, going back to the last talk where we talked about planning, you could like pre-mark your cot along the side to say height. That wouldn't be a bad idea. But you're going to figure out their inches, their height, if they're over 5 feet tall. You're going to find them on that center column where they're at, and that'll get you their height. And then we're going to go either left or right from the center column. This is genetic male, genetic female, and that is the math is already done. That's their ideal body weight. So for those that can read it, how much should a 5'8" man weigh? So we're going to look at what, 68 inches, and ideal body weight would be 68.4 kilograms. I'd encourage you to double check me because you know, I'm a human and I do dumb human things. But I used Excel to make this, and I just plugged in the formulas to Excel, and it did all the math for me. So using this height weight table, you can calculate their ideal body weight. So we got that. Everyone understand this? Everyone scanned that QR code? You get a copy of this if you want it. There's a second page that isn't on this slideshow that might be useful too. All right, so we got our ideal body weight. The next thing we want to look at is their minute ventilation. So the I-MET, the minute ventilation is how much gas we're going to put into the patient over the period of a minute. So that's a factor of our respiratory rate and tidal volume. So to figure out the minute ventilation, the mathy way for an adult is 100 mLs per kilo ideal body weight is what their minute ventilation should be. So we're all ready to do math, right? Minute ventilation is measured in liters per minute, so you're going to have to convert 100 mLs per kilogram into liters. Sorry, so here's the shortcut. You take their ideal body weight and you move the decimal spot 1 point to the left. So our 5'8" tall man, his ideal minute ventilation should be 6.8 liters per minute, all right? Makes sense? So ideal body weight, minute ventilation. Next would be the tidal volume. So this depends on our strategy. So when we look at our strategies, generally there's a lung protective and an obstructive strategy. And our lung protective strategy, we want to not overstretch the lung. Our obstructive strategy, we don't want to ventilate the person so much they don't have time to exhale. So 6 mLs per kilo on either strategy is not the worst starting point. Whatever your shops tell you is a good idea. This table that I did all the nerdy math on does 4, 6, 8, and 10 mLs per kilogram for male and female based on their ideal body weight. You can just go to what they're, so if we wanted to do 6 mLs per kilo on our 5'8" man, what should his tidal volume be? .8 liters per minute, minute ventilation. Our tidal volume, if we wanted 6 mLs per kilo, is going to be 410. Make sense? So the less math we have to do with an intubated patient in front of us, probably the better that patient's going to do. At least in my case, all right? So ideal body weight, minute ventilation, tidal volume. So the other factor is the respiratory rate, right? That's how we get our minute ventilation. So you could divide the minute volume by the tidal volume, and that'll tell you about your respiratory rate. This is one spot where you probably should do a little math, pull out your iPhone or Android if you're better than everyone else, and do some math, and you'll be able to figure out the respiratory rate. That's what R stands for in the requirements. So I meet the requirements: ideal body weight, minute ventilation, tidal volume, respiratory rate. That makes sense? Yes? Okay. So those, if we went back to John's garbage vent, those are the base settings you want to figure out. You're going to program those into your ventilator, and that's a starting point. And then you're going to put it on your patient. From there, we see how they do. So when we actually look at putting it on the patient, I talked about cognitive offloading tools, right? We have another one that we use at my shop that looks something like this. They're laminated and put in the vent set, every one, so that we don't forget like the important things. And a lot of these things made it their way onto the list because we did training and people forgot really simple, obvious things. That's not a dig on my folks. They're humans and they do what humans do, which is dumb things when they're under stress. So this is a 2-player game, setting up and applying the ventilator. Player 1 has the card in their hand. Player 2 has the vent in their hand. So player 1 reads a line. Player 2 acknowledges that line's direction. Then player 1 goes to the next line. Make sense? So we would select proper profile. Our ventilator has multiple options. So we would select if we're doing an adult, a pediatric, or non-invasive. Then we would make sure we've got the right circuit because we can do pediatric stuff. We've got a pediatric circuit and an adult circuit. Then we would select our strategy. Are we going to go lung protective or are we going to go obstructive? The early version of this card just said lung protective or obstructive. And then people came back and we found out in training, people were saying, well, but that's cool. But like what's obstructive and what's lung protective? And in stress, your brain does dumb human things. So we put the dumb human things on the list. So if it's not asthma or COPD, then it's not obstructive. Everything else is lung protective strategy. That makes sense? So then the way our ventilator is set up, if you went in this middle column, the mode, breaths per minute, tidal volume, PEEP, FiO2, if you went top to bottom, reading it on this list, along the button layout, you're going from the bottom to the top. So we kind of laid it out smartly like that. We'd go through our things. We would make sure our circuit's intact. We would make sure we got a filter line in place. Believe it or not, that was a huge problem. Like we had a lot of people forgetting it in practice and even in real life where they weren't putting the Untitled on. We're also well programmed to put on Untitled, but in stress, humans do dumb things. So if we put it on the checklist and Joe's reading me the checklist and it says filter line in place, I go, oh, actually, hang on, I forgot. Okay, cool, now my filter line's in place, and then let's put it on the patient. This is a starting point. Just like I meet the patients I meet the requirements every time. It's a starting point. So the E in every time is we're gonna evaluate our patient. The things we wanna evaluate once we get all of our settings. Are they tolerating it well? Are their vitals trending well? Are they becoming hypoxic? Are they becoming hypercarbic? Do we need to change stuff? Also, is the patient comfortable? And just for anyone who needs to see it, this next slide, it's really the most important slide of this presentation. Okay, it's the most important slide. Please, benzos aren't pain control. Please don't give just benzos. Give pain control too. So back to John's garbage van. We've made our settings. We've put it on our patient. We're evaluating the patient, and we're going to start trending and then titrating any effects. So every time, evaluate, trend, and titrate. So our ventilator, we've got some pressure monitoring things. This is kind of a more advanced thing. We can measure the peak inspiratory pressure. That's a pretty big deal. High peak inspiratory pressure is not so good. In the other setting we can monitor is called a plateau pressure or a P-plat. That's also really important. So we can make a kind of a garbage drawing like this. And what we're looking at, so if we follow this line on our graph, as it comes across this x-axis, it goes up in pressure, it reaches a peak. So that peak of that graph, that's where your peak inspiratory pressure comes from. All right, the way I like to teach this is like blood pressures, okay? So let's say we're on the truck and we've got a patient and they have a blood pressure of 210/70. Is anyone calling that a hypertensive crisis and like starting some cool drugs? I don't see any hands, any head nods. Okay, so let's say we're not, because high systolic but an okay diastolic in our setting, we're not too tore up about, right? Now let's take that same patient and say they have like splitting headache. Their blood pressure is 210/140. Is anyone a little more antsy about that? If you've got the right drugs for treating it, please do. If you don't have the right drugs, please don't. Nitro is not the right drug for that case, but that's a whole nother talk. So when we think systolic, diastolic, now let's take that kind of same mindset to this pressure graph. Systolic is your PIP, your peak inspiratory pressure. All right. Ideally, in a perfect world, we would love almost said systolic. We would love a peak inspiratory pressure greater or less than 35. That's awesome. That's super great. We're super happy if we can keep their peak inspiratory pressure under 35. Then our diastolic would translate to the plateau pressure. So when we're looking at our graph, we got our peak, right? And then it kind of drops off a little bit. So the drop off is the alveolar pressure. How much pressure is actually at the alveolar level? If you do this on a ventilator, you got to do a maneuver called an inspiratory hold. It holds their breath for like 5 seconds and measures this pressure. This is the more important of the numbers in my opinion, because plateau pressures greater than 30 is linked to the development of ARDS. And it's not ARDS like, oh man, you just got sick and it was too bad. It's caused by medicine ARDS, not like your disease is just bad ARDS. Does that make sense? So we really want to try to make sure if we can measure plateau pressure, we don't want to cause ARDS. So the systolic maps out to the PIP, the diastolic maps out to the P-plat or the plateau pressure. Those are really important settings we should be able to monitor if you've got a ventilator that can do it. There's some fancy ventilators out there like the Hamilton T1. It's kind of got like an easy button where it does everything automatically. That's really cool. I don't know a lot about it. I don't have them. I don't work with them. I like, as a paramedic, being able to do stuff, and like, I like the ability to make the settings what I think they need to be. This is not like a set it and forget it type of device. This is not a set it and forget it type of intervention. Just like an IV drip or any other invasive thing we do to a patient. Ventilators need our attention. They need to be changed. They need to be titrated to each patient. It really makes my insides die when I go on any interfacility transfers and you walk in and the patient's on the vent in the ER and their respiratory rate 16 and their tidal volume is 500. Does it work? Yeah. Is it the best thing for the patient? No, probably not, but it's okay in the moment. But if we've got the intelligence and the ability to make things better for the patient, we should probably make things better for the patient, right? So ventilators in 20 minutes, I match the requirement every time. I figure out the ideal body weight, the minute ventilation, the tidal volume, the respiratory rate, put the thing on the patient, and then evaluate how the patient likes the vent, change the things you need to change, trend how they're doing, and titrate whatever settings need to be titrated so that we optimize the patient. Have I been 20 minutes? Because I could keep going. I've done 20 minutes-ish. Okay, yes. Right. All right. That's a fantastic, so for the internet, the question was, very few, if any, of our patients are their actual ideal body weights. Should we be concerned about their total body weight as opposed to their ideal body weight? So where I push back is a 5'6" tall frame has the same size organs no matter how much weight is loaded onto it. So there are some things where we do think about total body weight, and it's like medications that get into the adipose tissue and stuff like that. But as far as like the air lung, you know, the lung volume, it should be pretty consistent. You would see higher pressures in those kind of people that have a lot more weight loaded onto their frame, because it's going to take more pressure for the ventilator to push stuff up. And that's, you know, previous talk where we talk about positioning, that's where positioning matters. Folks on vents should not be on their back. Couple reasons, but gravity isn't our friend. So that's that. So at my shop, we have the vents, and we're still getting familiar with these newer vents. And I get a lot of calls at all hours of the day about like troubleshooting things like, hey, this thing's blowing up and I can't figure it out. I appreciate my crews doing that. That's really cool. I like to be able to help. But there's some things we should know and be able to figure out, right? So the minute ventilation stuff, if we're putting too much tidal volume in a patient, we're going to see higher airway pressures. Sometimes we got to put a lot of volume in a patient. They're just a big person. Sometimes their airways are just garbage. There's this weird respiratory disease that's going around and infecting like gajillions of people and killing a bunch of them. That makes their airways like just wrecked, okay? Those patients require higher airway pressures. So sometimes the problem is the patient, sometimes the problem is the ventilator and the settings, and sometimes, most times, it's probably us. We're not thinking about what's wrong with the patient and adjusting our settings based on that. We're not programming the vent entirely. If you're the type of medic that does interfacility trips, it's a meaningful question to ask, like, what's their alarm parameters, not just what's their ventilator parameters. Because if they have some garbage lungs and their airway pressures just run high, you should probably program your vent to manage that. Because otherwise, you're going to want to drop kick the thing out of the back of your truck, because it will never stop alarming. So last little bit of John's ramblings. There are, let's look at my garbage ventilator. There's two settings on this vent that affect oxygenation, and only two. What are they? There's only two dials on here that'll affect the oxygenation of the patient. What are they? FiO2, that's one of them. PEEP, that's right. Okay, those are the only 2 settings that affect oxygenation. Now, obviously, like if there was an on button, I would say there's 3 settings. On is implied. If we put more oxygen gas in their lungs, they're going to oxygenate more. If we put some PEEP at them, it'll stretch out their alveoli. There's more surface area for oxygenation to occur on. That's it. If they're hypercapnic, there's only 2 settings on here that affect hypercapnia or CO2. What are they? I heard it. What'd you say? Someone say rate? Rate? Okay, so breath rate and tidal volume. Yes, okay. So if they're hyper or hypocapnic, the only settings that affect that is the rate and the volume. Those 2 settings are your minute ventilation. That's what drives your CO2. If you ventilate faster, you're going to blow off more CO2, or you ventilate more gas every breath, you're going to blow off more CO2. Nothing to do with oxygenation in those 2 settings. So if you ever decide to take like the IBSC critical care paramedic or flight paramedic exams, there's a bajillion ventilator questions, and almost all of the questions are fixed with either a hypoxia problem or a hyper or hypocapnia problem, and adjusting those settings will fix your problems. Turns out real life's like that too. If your patient's hypoxic, they probably need more oxygen. Who knew? If they're hypercapnic, they're going to breathe faster. Maybe we should make the vent do what they're going to do anyways. All right, I ramble, I rant. That's my ventilator talk in 20 minutes. It's not the super deep, weird stuff, but I think this is the most common problems we encounter in vents, and this is the most common introduction to ventilators. If you want a copy of those little cheat sheets I've got, if you didn't catch the QR codes, see me later. Thanks for your attention, and thanks for my friend Will Scott Smith at Air Methods for sharing his tactics with us so we can share them with other people. Any questions for me? Comments? Did I get too nerdy?